Imagine, just for a moment, if your body had this extraordinary ability to heal itself, like really regenerate and fix injuries that might normally put you on the sidelines for months, maybe even years. It's a powerful thought, right? And it's really at the heart of our deep dive today. We're digging into regenerative medicine. Specifically, things like platelet-rich plasma PRP injections and these, cutting-edge stem cell therapies, and how they could potentially help with those stubborn orthopedic injuries. This isn't really for you, to help cut through some of the noise and get to the core of why these treatments are, well, so exciting, but also why they can be so difficult to access, especially if you happen to be a federal employee dealing with workers' compensation. And look, while we're focusing on federal employees today, the kinds of policy hurdles and advocacy challenges we're talking about, they're pretty relevant to how any new treatment finds its way to patients across the board.
That's absolutely right. When we talk about regenerative medicine, we're really discussing treatments that try to harness the body's own sort of innate healing power. Take PRP, for instance. It involves taking a bit of your own blood, spinning it down to concentrate the platelets, which are just packed with growth factors, and then injecting that concentrated plasma right back into the injured spot. The idea is to kickstart, maybe accelerate that natural healing process. And then stem cell treatments, well, they often use what are called mesenchymal stem cells. These might come from bone marrow or fat tissue. They have this amazing ability to turn into different cell types, and help repair or regenerate damaged tissues. But the central problem, the real issue we're looking at today, especially for federal employees with those work-related muscle or joint injuries, it's whether the U.S. Department of Labor's Office of Workers' Compensation Programs, that's OWCP, whether they actually cover these innovative therapies. Our sources really dig into this question. So today, our mission, if you will, is to explore this whole thing.
We'll look at OWCP's current stance, how it stacks up against others, the compelling benefits we're seeing, the reasons behind the denials, and maybe most importantly, what steps could actually be taken to push for change.
Okay, let's unpack this right away then. What does OWCP's current policy actually look like for someone who's injured on the job and thinking, hey, maybe PRP could help me?
Well, simply put, OWCP does not routinely cover PRP or stem cell injections for orthopedic injuries. That's the bottom line right now. They've been pretty consistent in denying authorization. They usually call them not medically necessary or label them as experimental or unproven.
And the sources we looked at give some pretty clear examples of that, don't they? Like, there was a 2022 note from a DOL medical advisor saying PRP was, quote, not shown in well-controlled studies to be superior to more cost-effective therapies.
Exactly. And another case from 2020, OWCP consultants said a PRP injection was not medically necessary because the evidence just didn't show it was superior over other techniques.
Seems like a fairly solid wall there, a long-standing position.
It does, yeah.
So that's OWCP's take. But is this, unique to them? Or is this how other big federal programs are handling these therapies, too? Is OWCP an outlier here?
Here's where it gets really interesting. OWCP's restrictive stance. It's actually not entirely unique in the big picture of insurance. A lot of insurers, both public and private, they also tend to label these therapies as investigational. Take Medicare, for example, the big federal program for seniors. They generally don't cover PRP for most orthopedic stuff, like arthritis. They cite a lack of proven effectiveness. They've only really allowed it in very specific, limited cases, maybe for certain chronic wounds, and usually only if it's part of a clinical trial.
Okay, so Medicare's cautious, too.
Right. But then there's Tricare. That's the health program for the military and their families, and they've been a really notable exception. Back in 2019, Tricare actually launched this 5-year provisional coverage for PRP, specifically for chronic, mild to moderate knee osteoarthritis, and also for lateral epicondylitis, that's tennis elbow. Now, there were specific conditions attached, but the point is, they did it. It was basically a 5-year test run. It kind of acknowledged the promise, set a precedent that OWCP seems to be, overlooking.
A 5-year pilot, that's significant. Is that still going?
Actually, that provisional program is set to end in late 2024. So the results of that experiment will be really interesting to watch. But apart from that Tricare pilot, most other insurance plans think federal employees' health benefits, FEHB plans, or typical private insurance, they generally don't cover PRP or orthopedic stem cell injections either. They mostly class them as experimental. In fact, no major private insurance covers orthopedic stem cell injections at all, period. Even the VA, the Department of Veterans Affairs, doesn't have one single policy. Some VA centers might offer PRP sometimes, but there are advocates pushing hard for broader coverage through legislation.
Okay, so the bottom line then for federal injured workers listening right now is that OWCP currently does not cover these treatments. You're likely looking at paying out of pocket, which, yeah, that can be a huge barrier.
Precisely. OWCP's denials really reflect a conservative, sort of evidence-first policy. They're basically waiting for rock-solid scientific consensus that these injections are definitely better than the standard, often cheaper, treatments they already cover. But, like we said, this is happening while the medical research is just evolving so rapidly. It keeps pushing the boundaries, and that creates this real tension between the established policy and the emerging science.
Right. Despite those coverage hurdles, though, the research we dug into really highlights some significant benefits. So why are so many people seeking these treatments out, even paying for them themselves? What's the big draw?
Well, the fundamental difference is that these therapies aren't just about masking symptoms. Their goal is to actively repair and regenerate the damaged tissues. And if you think about the bigger picture, this translates into some really key advantages. First, there's pretty solid evidence for improved pain and function. We saw a big meta-analysis that's a study of studies looking at randomized controlled trials. It found that PRP injections for knee osteoarthritis led to clinically significant improvements in pain and mobility. And that was measured at 3, 6, and even 12 months compared to just a placebo. They use something called WMX scores to measure this.
WMX scores. That's like a standard questionnaire for arthritis symptoms.
Exactly. It assesses pain, stiffness, and physical function. So better scores mean people are feeling and moving better. And PRP for chronic tendon issues, like that tennis elbow we mentioned. Studies show it can offer better long-term pain relief and even improved grip strength compared to the usual steroid injections, which again lines up perfectly with why Tricare decided to run that pilot program.
Okay, those WMFC scores sound convincing, but what about those stories, like people actually getting back to work? How common is that return to full-duty outcome? Are there specific injuries where these treatments really seem to shine?
That's a really good question. Individual results always vary, of course, but the potential to get back to work faster is definitely a major attraction. We came across one example, a federal worker whose doctor specifically noted that PRP treatment allowed her to return to full duty after a pretty debilitating injury. It seems particularly promising for those chronic tendon and ligament problems and maybe moderate osteoarthritis, where the underlying tissue just needs that extra support to heal properly. And second, there's the really significant potential to avoid surgery and maybe avoid long-term disability that can come with it. Stem cell therapies, in particular, can be genuinely regenerative for conditions that might otherwise push someone towards a big operation. Another meta-analysis we looked at found that mesenchymal stem cell injections into arthritic knees. They significantly improve knee pain, physical function, and get this, even the quality of the cartilage seen on imaging. And those benefits lasted for up to 1 or even 2 years. So these treatments might stabilize the degeneration, reduce inflammation, potentially delay, or maybe even avoid needing joint replacement surgery altogether. And think about that, it's not just good for the patient's health. It's also a potential win economically for workers' comp, right? By avoiding the huge costs of surgery and all the rehab that follows.
That makes total sense. Avoiding surgery, yeah, better for the patient, obviously, but also a massive potential cost saving for the system. Okay, what about the procedures themselves? Are they safe? What's recovery like?
Yeah, safety and recovery are definitely big pluses here. Both PRP and properly prepared orthopedic stem cell injections have shown really strong safety profiles in the studies we reviewed. With PRP, because it's coming from your own blood, the risk of an allergic reaction is practically zero. The main side effects are usually just some temporary soreness at the injection site. The knee osteoarthritis trials for PRP, no serious complications reported. And similarly, stem cell treatments also report, no severe adverse events, maybe some minor temporary pain or swelling, but that's usually it. And crucially, these are almost always outpatient procedures. You go in, get the injection, and go home. There's minimal downtime. People can often resume light activities pretty quickly. That means way less time off work compared to the long, drawn-out recovery periods you often see after major surgery.
Okay, less risk, faster recovery.
And finally, what's really fascinating, I think, is how they work biologically. Unlike steroid shots or painkillers, which mostly just, manage symptoms or mask pain, regenerative therapies aim to address the underlying tissue damage itself. PRP works by stimulating tissue repair, calming inflammation, improving blood flow to the area. Stem cells, they can differentiate into various needed cell types, plus they release factors that encourage regeneration and modulate inflammation. They basically enhance the body's own natural healing capacity, potentially leading to longer-lasting relief.
Wow, it really does sound like a potential game changer for a lot of people. Faster recovery, avoiding big surgeries, actually healing the tissue. Given all these upsides, what is the fundamental sticking point for OWCP? Why are they still so hesitant?
That really is the million-dollar question, isn't it? And it's complex. Look, while some studies might have mixed findings, science is rarely unanimous. Especially early on, the overall trend in the research literature is looking increasingly positive, especially for PRP in knee arthritis. Multiple big meta-analyses have confirmed it offers significant benefits over a placebo, and the fact that Tricare, a major federal health program, experimented with coverage for 5 years, that clearly indicates that experts do see real promise here. But when advocates run into those OWCP denials, understanding why these treatments felt like they were pulled away is key. OWCP operates under the Federal Employees Compensation Act, FECA, and that law requires treatments to, quote, cure, give relief, or reduce disability. Their medical consultants tend to stick to very conventional standards of care. And based on their review, they find the current evidence isn't quite strong enough yet to prove these treatments effectively improve outcomes beyond what the cheaper traditional options already provide. That phrase we heard earlier keeps coming up. Not shown to be superior to more cost-effective therapies. OWCP is essentially asking, why should we pay potentially more for this injection if we're not definitively convinced it's better than physical therapy or a standard steroid shot?
Okay, so it's that superiority bar again. But this is fascinating. What we gathered suggests these policy shifts, the tightening up, it wasn't always transparent. It wasn't like there was a big public debate or Congress passed a new law. It sounds more like a quiet internal change in how they interpreted the existing rules. And that suddenly impacted thousands of people. That sounds like a recipe for, well, a lot of frustration and maybe a bit of a trust deficit.
That's precisely the insight, yes. Back in the early 2010s, some federal claimants actually did get PRP authorized. Sometimes it worked well for them. But then by the late 2010s, around 2019, 2020, OWCP quietly, internally, tightened its policy. Denial started becoming the norm. And this happened largely through internal bulletins or directives, not through, say, widely published announcements. So for providers and injured workers, it really did feel like these therapies were suddenly yanked away without any clear public notice or explanation. There was very little external guidance published about the change. And yeah, that definitely fuels frustration and that sense of mistrust you mentioned. This also brings up the important issue of cost and precedent concerns. Regenerative treatments aren't cheap. We're talking maybe $500 to $1,000, sometimes more, for just one PRP injection. Stem cells can be significantly more expensive than that. OWCP, like any insurer, is naturally cost-conscious. They likely fear opening the floodgates to a huge number of requests if they started covering these widely. And they might also be worried about setting a precedent. If they approve PRP, what about the next new treatment that comes along? It could lead to spiraling costs down the road. So OWCP tends to err on the side of caution and, frankly, frugality, which unfortunately can mean denying access to cutting-edge care that might genuinely help people get back on their feet. Now, legally, OWCP's decisions can't be completely arbitrary or unreasonable, and the Employees' Compensation Appeals Board, the ECAB, has often sided with OWCP, upholding denials when the clinical evidence is still mixed or developing. So while OWCP is basically following the mainstream medical consensus as they see it, the problem is that medical consensus evolves, sometimes really quickly. And this creates that fundamental tension, that gap, which really sets the stage for the kind of advocacy we need to talk about.
Right. So it really boils down to skepticism about just how effective these are compared to standard care, plus worries about the cost, and all of that compounded by this lack of transparency around how the policy actually shifted. It's almost like a classic catch-22, isn't it? Without coverage, it's harder to gather the large-scale, real-world data that might finally convince them.
Exactly.
But thankfully, the sources we looked at don't just leave us there feeling frustrated. They actually offer a pretty concrete action plan for advocacy.
Yes, absolutely. If the goal is to see coverage reinstated, then a proactive, strategic advocacy and engagement plan is definitely needed. It won't happen on its own. The first step, really, is to compile and present the most up-to-date evidence. This means gathering the latest clinical research, especially those strong meta-analyses and randomized controlled trials we talked about. But it's also crucial to highlight compelling success stories. Real examples of federal workers who maybe avoided surgery or got back to work much sooner because they had access to PRP or another regenerative treatment, perhaps paying out of pocket. This evidence needs to be packaged effectively, maybe in a formal white paper or a comprehensive report that can be presented directly to key people at the Department of Labor and OWCP.
Okay, armed with the data, what next?
Next, you need to engage the key stakeholders and build broad support. This is critical. Federal employee unions and associations think groups like the APWU for postal workers or the NALC for letter carriers. They need to be educated on this issue and mobilized to lobby OWCP and maybe even Congress directly. Their voice carries weight. Key medical provider groups like occupational medicine specialists, orthopedic associations getting their endorsement would be hugely influential. And engaging lawmakers who might be sympathetic to the cause is also vital. You need to build a really broad coalition of support to genuinely move the needle on policy.
Makes sense. Strength in numbers.
Definitely. And another very practical approach is to propose a pilot program, or maybe a provisional coverage period, kind of like what Tricare did. You could suggest OWCP authorize PRP, let's say, just for chronic knee injuries or maybe tennis elbow cases that haven't responded to standard care. Do it on a limited controlled basis initially. And during that pilot, you'd rigorously track the outcomes. Are people recovering faster? Are they needing fewer surgeries? Using fewer opioids? Are they getting back to work successfully? Gathering that kind of data directly within the OWCP system could provide the justification needed for permanent coverage. It appeals directly to OWCP's own evidence-based mindset because you're actively gathering evidence for them.
Sort of proving the concept within their own system.
Exactly.
Yeah.
And alongside that, it's absolutely essential to highlight the potential cost savings. This needs to be front and center in all communications. We have to emphasize the clear cost benefit for OWCP. Chronic orthopedic injuries, surgeries, long recoveries, they're incredibly expensive. Not just the medical bills, but also the wage loss compensation paid out while someone's off work. If a course of PRP or stem cell injections costing maybe a few $1,000s can help someone avoid a knee replacement that costs tens of thousands plus months of lost wages, well, OWCP could actually save significant money in the long run. Making that economic case very clearly is vital. We should even push for OWCP's own actuaries or analysts to perform a dedicated cost-effectiveness analysis. Let them run the numbers.
Right. Show them the money, essentially.
Pretty much. And finally, we need to demand more transparency and collaboration. Part of the frustration, as you pointed out, was policies changing seemingly without notice. Advocates should push OWCP to openly publish any medical policy bulletins or the specific criteria they use for approving or denying these newer therapies. Make it clear. And establishing a direct dialogue with OWCP's medical leadership would be huge. Maybe through regular stakeholder meetings, or even setting up an advisory panel that includes physicians with expertise in regenerative medicine. That fosters collaboration rather than an adversarial relationship. It ensures that if OWCP does modify coverage in the future, it's a communicated change, not a surprise out of the blue. That helps rebuild trust. And it's really important to stress that qualified providers are actually ready and willing to step up right now. For instance, clinics like Restore Muscle and Joint, with locations in Kansas City and St. Louis, they operate as federal injury centers. They're already deeply familiar with the OWCP claims process. They successfully use PRP and stem cell therapies for their private pay patients already. They have the expertise. They are basically poised and ready to offer these services to injured federal employees if and when OWCP coverage gets reinstated. Their teams combine that regenerative medicine expertise with the specific knowledge needed to handle OWCP documentation. Having trusted local providers like them ready to go could be a huge benefit for federal employees in that region, and they could help demonstrate the real-world effectiveness and potential cost savings we've been talking about.
Yeah, it's definitely reassuring to know that there are clinics already equipped, ready to deliver these treatments safely and effectively, and ready to contribute that crucial real-world data once they get the green light. Okay, so we've covered a lot of ground today. We've explored this really exciting frontier of regenerative therapies, looked hard at OWCP's current restrictive stance, discussed the really compelling benefits these treatments seem to offer, dug into the reasons for the denials, and importantly, laid out a clear, actionable path forward for advocacy.
Yeah.
It really reinforces the core message, doesn't it? These treatments genuinely seem to offer healing and real hope for people dealing with chronic pain and mobility issues. And that aligns perfectly with the goal of getting injured workers back to full duty, preventing long-term disability.
Absolutely. And while these treatments are, for the most part, withheld right now for federal workers under OWCP, the landscape is undeniably shifting. The research keeps accumulating, and that precedent set by Tricare's pilot program is significant. It really does feel like it's time for OWCP to seriously reconsider its sort of blanket exclusion of regenerative medicine, at least for certain conditions where the evidence is strongest. And that collaboration we talked about among OWCP officials, union leaders, healthcare providers, that's going to be absolutely key. And again, clinics like Restore Muscle and Joint in Kansas City and St. Louis, They stand as examples of providers who are ready to lead the way, ready to demonstrate effectiveness as soon as that door opens for federal employees.
So as you, our listener, reflect on this deep dive, maybe consider this question. In a world where medical innovation is just constantly pushing boundaries, how do we strike the right balance? How do we balance that cautious, evidence-based policy approach with the really urgent need for injured workers to access the best possible care? Care that could truly restore their function, their quality of life? It's a question that honestly goes way beyond just federal workers' comp. It touches on how quickly our healthcare systems adapt to breakthroughs and make sure everyone can benefit. What more can we do system-wide to bridge that gap between innovation and access? It's definitely a journey we'll continue to watch and learn from. Thanks for